Hi everyone, and welcome to another video of pharmacology questions and answers. Let's have a look at the first question, which involves drug interaction. A 70-year-old man takes cimetidine twice daily to manage symptoms of GERD-related esophagitis. He also occasionally uses sildenafil for erectile dysfunction. His physician advises that cimetidine can interfere with the metabolism of sildenafil, reducing its effectiveness, and recommends switching to an alternative medication. Which of the following changes would be the most appropriate to prevent a significant drug interaction? A. Calcium carbonate for cimetidine. B. Magnesium hydroxide for cimetidine. C. Nizatidine for cimetidine. D. Omeprazole for sildenafil. E. Tadalafil for sildenafil. Now the key point here is that cimetidine inhibits the cytochrome P450 enzyme system. This enzyme family is responsible for metabolizing many drugs, including sildenafil. When cimetidine inhibits this enzyme system, it can alter sildenafil's breakdown in the body. So we need to recommend an alternative to cimetidine that does not interfere with this enzyme system while still effectively manage the patient's esophagitis. Hence, the correct option would be C. Nizatidine for cimetidine. Nizatidine is another H2 receptor antagonist like cimetidine, which reduces the stomach acid production by blocking histamine receptors in the stomach lining. Importantly, nizatidine does not inhibit the cytochrome P450 system. This means it can effectively manage esophagitis symptoms without interfering with sildenafil metabolism. This makes it the ideal choice for this patient as it addresses both GERD and drug interaction concerns. Let's have a look at why the other options are incorrect. Option A is incorrect because calcium carbonate is a weak base that can help relieve symptomatic acid reflux. However, it's not an appropriate substitute for treating esophagitis. Esophagitis often requires a more sustained reduction in acid production, which calcium carbonate cannot provide. Therefore, this option is not suitable. Option B is incorrect because similar to calcium carbonate, magnesium hydroxide can neutralize stomach acid and relieve mild symptoms of reflux. However, it's also inadequate for treating esophagitis, which requires stronger acid suppression to allow healing of the esophageal lining. Option D is incorrect because replacing sildenafil with omeprazole does not solve the issue. While omeprazole is a proton pump inhibitor that suppresses gastric acid, it does not address the patient's erectile dysfunction. Additionally, omeprazole is also metabolized by cytochrome P450 system. And option E is incorrect because swapping sildenafil for tadalafil is not a viable solution because tadalafil is also metabolized by the cytochrome P450 system. The underlying drug interaction problem would remain unchanged, and there would be no benefit to make this substitution. Let's have a look at the second question. A 55-year-old man visits his cardiologist for management of poorly controlled hypertension. He has a history of asthma. In the past, he has experienced adverse effects with angiotensin-converting enzyme inhibitors, angiotensin receptor blockers, and calcium channel blockers. If the cardiologist plans to add a beta blocker to the patient's treatment plan, which of the following options would be the most suitable choice to address his hypertension? Option A, propranolol. Option B, esmolol. Option C, labetalol. Option D, metoprolol. Option E, nadolol. The correct option here would be D, metoprolol. Metoprolol is a cardioselective beta-1 blocker, meaning it primarily affects the heart without significant impact on the beta-2 receptors in the lungs. This makes it an ideal choice for managing hypertension in a patient with asthma, as it minimizes the risk of bronchoconstriction. In order for us not to be confused with the location of beta-1 and beta-2 receptors, always remember we have one heart and we have two lungs. So beta-1 receptors are located in the heart and beta-2 in the lungs. Let's have a look at why the other options are incorrect. Option A is incorrect because propranolol is a non-selective beta blocker, meaning it blocks both beta-1 and beta-2 receptors. By blocking beta-2 receptors, it can trigger bronchoconstriction and exacerbate asthma. This makes it a poor choice for this patient. And option B is incorrect because esmololol is a cardioselective beta-1 blocker which is safe for asthmatics, but esmololol is used only in acute settings such as surgeries or hypertensive emergencies, and this is because of its short half-life of 10 minutes. It is not suitable for long-term hypertension management. And option C, labetalol, and option E, nadolol, are incorrect because they're non-selective beta blocker. So the correct answer here is option D because of three things. Number one, it selectively blocks beta-1 receptors, minimizing lung side effects. Number two, effectively manages hypertension in chronic settings. And number three, avoids bronchoconstriction, which is crucial for asthmatic patients.